So Patrick, many thanks for agreeing to meet. I went to your talk a few months ago, really, about brain attack and the services offered in Tower Hamlets. And I felt as a GP you had a lot of important messages, and it was useful to be able to get these messages to all GPs. There's something like over 300. And the meeting I went to, you might have been talking to maybe a dozen GPs who had to kind of make time to cycle to this meeting. You cycle to the meeting. If you work out how many people you're going to have to actually meet to do that, it's going to be hard work. So thank you for meeting. So can you sort of talk us through these slides that you showed us at that meeting? So if we think about the first slide, over to you. What do you feel we need to know?
Yeah, well, this is really a talk aimed at GPs, giving people the big picture, which is that stroke and TIA are medical emergencies, and the situation is very dynamic in the acute phase. And it's also referring to some of the secondary prevention that patients are on after discharge.
Right. Okay. So if we look at the first slide, in a sense, you're calling this brain attack. As we usually call it stroke. But tell us why that's what you feel.
This is an American idea to try and make stroke a bit like a heart attack. Yeah. But it's to get away from the idea that stroke's an inevitable consequence of aging. It's something that's treatable, and even in elderly patients, in fact particularly the older patients, the treatment makes a big difference to both disability and survival.
Right. Just tell us this.
Yeah, so this is some pictures that we took of an accountant in his late 50s who collapsed in the city a few years ago. On your left there's the coloured picture, and on the right there's the black and white one. The coloured one is I'm talking like this because I like using English terms rather than Latin things. I'm not trying to be patronising. The coloured picture is a perfusion scan taken about 40 minutes after the patient's developed symptoms. What happened to him is he collapsed with weakness down the left side, a complete paralysis, and an ambulance was called. He was brought to London. So what you can see is the red area, particularly where the red dots are close together, is an area where there's severe perfusion deficit, and that's like what we call the core infarct. And then further on down you can see yellow areas where perfusion is reduced, but it's not reduced so much as in the core. So the important point to make is that the reason he's paralysed at this point is that half of the brain has stopped working. It's not because it's dead. The only irretrievably dead parts of the brain are the deeply red bits. The yellow bits are potentially recoverable. That's the ischemic penumbra. So what you see is a paralysed patient, but what's happening in the brain is much more complicated than that. And that's shown by the CT scan that you can see on the right, which is taken the next day after the patient had thrombolysis treatment. So the vessel was opened up, and I've got pictures further on of what happened with the blood vessels. But the point here is that the area roughly corresponding with the red area on the perfusion scan acutely is now showing a developed infarct. But the area which was yellow, where the perfusion was reduced, has been salvaged, so that's the penumbra. So functionally, at this point, the patient has no paralysis. He's just got some mild cognitive and memory problems, even though and that's the response to the recanalization.
So what you're saying about you're talking about the one on the next day, is that correct? Yeah. So he's improved.
Yeah, he was almost complete recovery from thrombolysis, and this particular patient went back to normal activities after the stroke.
Okay.
So that's the big picture. Stroke and TIA are treatable medical emergencies.
Okay.
So I'm going to talk about the 3 treatments for stroke and TIA that are advocated by NICE. And then, of course, it's no good having a treatment if you don't spot the patients who need it. So I'm going to talk about how you recognise stroke and TIA. And then finally a little bit about the response, how you respond when you've made the diagnosis. And I'm going to take the opportunity to trumpet the results of the changes in stroke in London recently. So it is important to remember that one of the best treatments we've got for stroke is antiplatelets, and in the acute phase the only one which is evidence-based is aspirin. The trials are old now, the Chinese acute stroke trial and the international stroke trial, but they were huge. They had to be big because in those days they were treating people up to 48 hours after onset of treatment. So a lot of people who could have benefited perhaps didn't because they were treated late. In spite of that, they were able to show significant benefits in terms of survival and dependency with early treatment with antithrombotics, with aspirin.
So how early do you, I mean, in a sense, from a practical point of view, what are
we
you
give
saying?
it as soon as possible.
Right. So, but if we saw somebody in the surgery with, symptoms suggestive of a stroke, we could get just...
No,
no?
I wouldn't suggest that.
No.
I'll talk a bit about that later, but
okay.
Basically, if somebody has a stroke, they need a scan before you give them aspirin to exclude a hemorrhage. If it's a TIA and they've got better, then you should start them on aspirin.
Okay.
So the other treatment that's recommended by NICE is organised stroke care in a stroke unit. And this is one of the best treatments that you have in medicine nowadays. There's very few other treatments that reduce your risk of dying by nearly 20%. They also reduce your risk of being disabled or going to a nursing home very significantly. So this is a really powerful treatment. Important points about stroke units are that they have to be geographically defined. It's no good having experts visiting you on a ward where the nurses aren't stroke experts. The other important thing is that all patient groups benefit. Older patients, younger patients, very disabled patients or less disabled patients, it doesn't seem to matter. The stroke unit is still beneficial.
Now, I'm not terribly clear about how to read this slide. Can you just very quickly explain what it means?
So this is looking at, this is from the Cochrane analysis, looking at the odds ratio for death or institutional care, and death or dependency, three big outcomes, in randomised controlled trials. So the odds ratio of 0.82 means that patients randomised to a stroke unit had an 18% reduction in their risk of dying during the follow-up period. They had the 0.81 for death or institutional care is a 19% reduction in the combined outcome of dying or going to a nursing home. Right. And an analogous outcome, which is death or dependency, odds ratio of 0.79 translates to a 21% relative risk reduction.
And that's compared to just sort of standard kind of...
Yeah. The alternative would be going to a geriatric ward or a general medical ward without stroke specialty.
Okay.
This is a rather old slide from the Cochrane database, but this is just looking at the effect of recanalization of the blood vessel with thrombolytic treatment, specifically the agent we use at the moment, TPA, alteplase. And using alteplase to dissolve the clot, if you give it early enough, there is an overall benefit. So unfortunately there is a risk, and the risk is mainly of symptomatic intracerebral hemorrhage, which is the first bit of this forest plot here. And what it shows is that there is a risk of hemorrhage that seems to be more or less independent of time. So in the 0 to 3 hour period and 3 to 6 hour period, there's still a high risk of hemorrhage. So what you have to imagine is there's like a fixed risk, what we call an early hazard from this treatment. So which doesn't change very much with time. Because of that, if you look at the next segment, the risk of dying within 3 months is not changed very much. If you look at the bottom set of bars, the risk of dying or being dependent is reduced if you give the treatment within 6 hours, but the reduction is less at the 3 to 6 hours than in the 0 to 3 hours. So what you have to think of is that when you see patients like that accountant at the early stages after stroke, there is a chance that the treatment will recanalize the blood vessel. It's not 100% by any means. There's a chance that that recanalization will improve blood flow and that the brain cells will recover. And there's also a chance that he might have a catastrophic hemorrhage. So the chances of the good things happening get less and less with time. The chance of the bad thing happening stays the same. So the sooner you give the treatment, the more likely you are to have a good result. And the time window is now about 6 hours. But to give you a sort of an idea, if you treat people within 90 minutes, 1 in 3 will have what's called a Lazarus effect, a complete response to treatment. If you give it at 3 hours, it's only 1 in 6 will have that effect. And at 4.5 hours, it's 1 in 8. So the effectiveness of treatment dramatically declines with time.
Right. Now, just to be clear, if people have this thrombolysis, that confers some net benefit.
Yes.
And then if you're in a stroke unit, you get additional benefit.
On top
correct?
of that,
yes.
Okay. So this is just to put things into perspective. It's a trial I've borrowed from the third international stroke trial team, where they've compared what we know about the effects of aspirin, stroke units, and thrombolysis, and looking at it in terms of a population effect. So if you imagine that 80% of stroke patients get aspirin, that's because around 15 to 20% are hemorrhagic. That in the United Kingdom means about 100,000 patients being treated per year. And the benefit, which is relatively small per patient, 13 per 1,000, still translates to a large population benefit of 1,000 or more patients avoiding death or dependency because of being given aspirin. Stroke units, unfortunately not everyone gets to a stroke unit, but they benefit infarcts, bleeds, old patients, young patients. So even if you assume that only 60% of patients get to a stroke unit in time to make a difference, and that means only 78,000 people nationally being treated, because the benefits are so big, that means that you have 4,000 or more patients a year avoiding the death or dependency poor outcome. Now with thrombolysis, at a typical developed world rate of around 2%, that's what people are delivering in France and Germany and were delivering in England until recently. That, even though it has a lot of benefits for individual patients, is only suitable for a small number. That would, if you put it into perspective, only benefit about end up with about 130 patients with net benefit, avoiding the death or dependency outcome. However, the challenge is if you look at extending the use of thrombolysis to as many patients as possible by good organisation of stroke care in the front end, you could bring the overall effect on the population of thrombolysis up to being as effective as aspirin in the population terms, so around 1,500 patients benefiting.
Right, so my reading of this slide is that actually stroke units themselves confer significantly more.
That's the best thing.
That's the best thing. So
yeah.
if you had stroke units plus good organisation leading to more thrombolysis, that would be the best.
Yeah.
That's the aim.
Yeah.
Okay.
And when I come to what's happened in London, I'll give you a practical example of how all that works out.
Okay.
So that's stroke. I also wanted to talk about TIA. And until recently, TIA was thought to be a fairly benign condition, mini stroke. Part of that is because the epidemiology was all started following patients up at around 4 weeks after the initial TIA. And TIA clinics typically saw patients 6 weeks after the TIA, so the people that we saw in clinic usually did quite well afterwards. Now, if you look at this graph that comes from the Oxford Oxvasc study, where they followed people up from the day of the TIA, you can see that a typical TIA clinic seeing people at 40 days, all the bad events have already happened, and that's why it looks like the prognosis is good. In fact, if you look in the first few days after the TIA, and this population here is a population of referred patients, so possibly half of them didn't even have a TIA. This is people that GPs have referred to the clinic. 6% have had a stroke or death within the first 4 days after being referred. So this is something that in risk terms is similar to unstable angina. So we really do need, on looking at this chart, we need to think about changing our approach to TIA. Although the challenge is to say this is the outcome from a state-of-the-art TIA clinic, and they're still having quite a few people getting poor outcomes. However, the people who did the study, the Oxvasc study, changed their protocol in a few very simple ways, and see that from the next slide, that if they changed what they did with the patients, they had an 80% reduction in the poor outcome. And what they did is they used aspirin, blood pressure control, and cholesterol control, A, B, C, and that reduced the risk of TIA by 80%. The change was giving it straight away in the clinic rather than advising the GP to give it, and of course the patient, that's relying on the patient turning up to the surgery, getting the FP10 and so on.
And that's, will these people have had a CT scan or something like that too?
Well, in the Oxvasc protocol, they had a CT, it was a one-stop clinic where they had all the imaging they needed on the day, and then they got their treatment started.
So do you need a CT scan before giving them aspirin?
No, you don't, if it's a TIA. So the same group developed the well-known ABCD2 score, which is a way of predicting the risk of stroke or death after a TIA. And it basically picks out people who are most likely to be a TIA, and also some of the poorer prognostic signs, age, blood pressure, presence of hemiparesis, and length of symptoms, plus diabetes. And the score actually works quite well at predicting who's going to go on and have an event in the next few days. This is, as you can see from this graph here, showing the increased risk with different scores at different time intervals. But if you look at the original paper, the problem is that taking a cut-off of a score of 3 or less as being low risk and making everyone with scores of 4 or more high risk actually means you're left with 80% of TIA patients being high risk. So as I'm sure people in the audience have experienced, if you see someone who's hypertensive and elderly, then and a diabetic, they're almost all the way there to being high risk, whatever else happens. So to me, actually, I tend to like to see everyone as high risk, except for it's reassuring for the very low risk patients, some of whom turn out not to have had a TIA, but everyone is pretty high risk actually in this population. So I said that the treatment given in the Oxvasc clinic was A, B, C. A is for antithrombotics, and what we use now is a loading dose of aspirin 300 at the time you've made the diagnosis. So the first doctor who sees the patient should start that treatment, and you don't need to wait for a CT scan for that.
Right, so that could be the GP.
Should be the GP.
Yeah. Should be the GP.
Now that is then followed on by clopidogrel 75 milligrams a day at the first line anti-platelet agent. That's relatively cheap nowadays since it's off patent, and is better tolerated than aspirin and dipridamole by most patients. Second line, if the patient, for example, is allergic to clopidogrel, would be aspirin and dipridamole modified release, 200 milligrams twice a day. A lot of people get headaches with that combination, and the modified release dipridamole is relatively expensive. So lifelong clopidogrel for most patients. I must mention atrial fibrillation. Patients with acutely symptomatic atrial fibrillation, actually, this is now, we now recognise as an emergency. So these people need to be anticoagulated urgently with heparin if necessary, and in hospital if necessary.
So from a practical point of view, from general practice, somebody who comes in with the history suggestive of possible TIA plus atrial fibrillation, we should be referring to the medical team.
Straight, yeah.
Not to the stroke team.
Well, stroke team in London,
okay.
in Tower Hamlets,
okay.
yeah. Yeah. Okay, next. Now, B is for blood pressure, and essentially all patients benefit from lowering the blood pressure. Obviously, if you're hypertensive, you just treat to target. If you're normotensive, then ideally you want to reduce the blood pressure by about 10 millimeters of mercury systolic. This doesn't have to be done quickly, over a few weeks or months, as tolerated. And that will reduce the risk of a recurrent stroke by around 28%, even in normotensive stroke survivors. So commonly we would be nervous about treating somebody with very low blood pressure, 100 or 110 systolic, but even those patients in the trials benefited. So worth considering, and certainly in patients with systolics of 110, 120, worth trying to get it down by 10 millimeters of mercury.
So really that, in practical terms, is everybody?
It's nearly everyone.
Nearly everybody,
yeah.
okay. So even if they have normal blood pressure, we should treat them with perindopril?
Well, I've put those in, that's where the evidence is. In fact, what we're saying is probably just a class effect to do with lowering blood pressure. So I certainly wouldn't change somebody's medication to those drugs if they're already on something else. If you're starting from scratch, then a thiazide or an ACE inhibitor and amlodipine are probably very reasonable. But that's where the evidence happens
now,
to be.
what is the target? Because our present target is 140 over 90 across the board, even in people with diabetes. Well, no, not diabetes, but say ischemic heart disease. But you would say, if we have somebody like this, that actually, if say 130 over 80, we should still
go for 120. Yeah, set an individualised target.
Yes.
There doesn't appear to be a threshold effect. The graph showing benefit against blood pressure is a straight logarithmic straight line, which means that you get the same relative risk reduction for blood pressure lowering wherever you start.
Right. Okay.
And there's a similar story, in fact, with cholesterol. Here, the study I've got there is essentially driven by the heart protection study, which is quite old now, but in that group of patients with ischemic heart disease and cerebrovascular disease, they were able to show that even in patients with quite low cholesterols, lowering the cholesterol further by about 1 millimole per litre actually reduced the relative risk of stroke by around 20%. So what I would suggest is in stroke, I'm not very complicated. I just do a random cholesterol to exclude people with a low cholesterol from cholesterol lowering, and that means less than 3.5. And if once I've done that, I start people on simvastatin 40 milligrams a day, which it was chosen with heart protection study in that dose because that's seems to be the best balance between efficacy and side effects. Okay, so that was treating stroke and TIA. Recognising stroke and TIA is actually quite a challenge. You need to, there aren't any easy tests like an ECG. You have to do a clinical assessment. History and examination is what tells you what's going on, and particularly with TIA, by definition, there won't be anything on CT scan. So even in clinic with the tests, we're usually making a clinical diagnosis. So one way of approaching this is to think about the differential diagnosis of stroke. That is, patients who present with who are fast positive. That means they've got face, arm, or speech problems, but who then turn out not to have a stroke after they've had, or TIA after they've had tests. And the Newcastle group who developed the FAST score have got quite a lot of information about what the eventual diagnosis was in those patients who we call stroke mimics. They're fast positive but turn out not to have a stroke. And essentially it's the 4 S's: seizures, syncope, sepsis and somatization. Some people add a 5th S, space-occupying lesion, but actually that's quite rare. So if you're looking at in population terms, big groups are the people with fits who've had a faint or got generalised infection, or surprisingly common, patients with functional weakness. So this would be, just to put in perspective, around in the Newcastle study with ambulance crews applying the FAST test, about 20% of the people who they said were FAST positive had one of these 4 things. So if you're thinking about, on the positive side, how you positively identify stroke, what you need is some focal neurological symptoms and signs that fit with a vascular diagnosis. And essentially everyone with a stroke or TIA has one of these things: a paralysis down one side, a language disturbance, for example dysphasia, a sensory disturbance down one side, visual problems on one side, or visuospatial perceptual problems on one side. So you're looking for one of those things to make it a stroke. Someone who doesn't have any of that makes stroke much less likely. Obviously stroke patients have other symptoms and signs, and things like dysphagia or dysarthria, or unsteadiness with ataxia, double vision, vertigo or amnesia. They can occur in stroke, but on their own are less typical. So somebody with just dysphagia may well have something wrong with their throat or swallowing rather than a neurological cause. Similarly with diplopia, vertigo and ataxia, in population terms, just on their own, these are much more likely to be caused by vestibular system problems than problems in the central nervous system. There's an interesting study from the States where they fully worked up and investigated patients with pure vertigo without cranial nerve signs or neurological signs apart from nystagmus, and only 1 in 300 of them had a stroke. And amnesia also, on its own, is very untypical of stroke. There are also symptoms and signs that actually, if they're present with the other things, make stroke actually unlikely. So, and that's in things that suggest more generalised neurological disturbance, like weakness overall, or lightheadedness, or faintness, loss of consciousness with complete recovery and no neurological signs. That excludes the diagnosis of TIA, for example, and certainly excludes the diagnosis of stroke. Non-specific presentations like incontinence or confusion are more suggestive of sepsis rather than a stroke, and tinnitus on its own is very rare in acute stroke. So if you have these things, then you need to think again about whether it is a stroke or not. There's a score that helps with this called the Rosier score, which stands for Recognition of Stroke in the Emergency Room, and it's got very good sensitivity and specificity. And what you do is you look for loss of consciousness or fits, and you say, you give the patient -1 for either of those, and then you add 1 for any of the things that make stroke likely, like face weakness, arm weakness, leg weakness, speech disturbance, or visual field deficit. And a patient with a score of 1 or more is very likely to be a stroke. A patient with a score of 0 or less is quite unlikely to be a stroke. So that's quite useful.
So that's something we can use as
Yeah.
GPs.
So what do you do if you recognised a stroke? How do you respond? Well, if the patient hasn't fully recovered from their weakness, then it's a stroke. There's discussion about whether you can diagnose stroke or TIA in the first 24 hours. Some people get confused about that. If someone's got mild weakness, you often see in the house officer clerking a diagnosis of query TIA. They're trying to guess what's going to happen in the future. Rule of thumb is that because patients with TIA almost always resolve within an hour, the chances are, if you're seeing them and they've got a deficit, it's a stroke, and you should treat it as a stroke. So don't wait for people to recover, even if it's mild. Just call 999. If they have completely got better, then you should contact the stroke team at the London. We're available 24/7. And what we'll do with a high-risk patient, that would be someone with a high ABCD2 score or with atrial fibrillation, is we'll see them rapidly, either in A&E or in our TIA clinic that day, and investigate them and start treatment. We'll advise you to start them on aspirin and tell the patient not to drive, and then after that we'll go from there. If they're the relatively low-risk patients, that is people with a low ABCD2 score, not in AF, or possibly late presenters, because of course a common situation is someone with a high score but it's more than a week old. They turn into low risk if they're over a week. They can go to a less urgent TIA clinic within a week. Again, start aspirin and advise them not to drive. So finally, I just wanted to blow the trumpet about stroke in London. We're very proud of this. We think London is the best place in the world to have a stroke. There's no big city, including New York and Sydney and all those places where traditionally we feel would do better than us. There's no big city in the world that has developed a whole city organised response to stroke in the way London has. I think key features of the London model are that it is the whole population, it's not patchy, that it's all of stroke, it's not just thrombolysis candidates, and that all stroke patients go to one of 8 hyperacute stroke units. The investment was very small, amounted to about £23 million in the first year. It's already paid benefits. If you look at the health economic analysis, in London we're spending less overall on stroke than the rest of England. We also have a remarkably reduced mortality from stroke compared to the rest of England. And if you look back at if you think at the thrombolysis slide that I showed you, thrombolysis doesn't affect mortality, it just affects disability. The mortality comes from early access to stroke units. And that's where we think why we're doing better than, say, Manchester, where only thrombolysis candidates are diverted to the HASU. In Manchester, there's no difference in stroke mortality between Manchester and the rest of England. We're achieving thrombolysis rates of nearly 20% now of all strokes. And the average journey time, to reassure people who are nervous about the consolidation of services in only 8 centres, the average journey time is only 14 minutes. This still takes an hour for people to get to hospital on average, and that's mainly because of time spent on the scene by the paramedics, because they often face challenging situations. So it's not affected by the location of the unit, how quickly you get treatment. In London also, it's worth mentioning that we are achieving very, very rapid, what we call door-to-needle times for thrombolysis. So I said earlier about how critical time is in terms of the effectiveness of the treatment. In London, we are achieving overall in a median door-to-needle times of less than 30 minutes. So half of patients are being treated. That's scans, the complex assessment, are being treated within 30 minutes of arrival in A&E. And that is something that reflects the organisation of care within hyperacute stroke units.
And presumably London Ambulance are teed up for this.
Yeah, all ambulance crews are all trained in stroke recognition and the early management of stroke.
And this will be almost exclusively patients dialing 999 because they're not, if they were to come to the GP, that, from a practical point of view.
Well, some people go to a GP surgery and then, just like with chest pain, GPs call 999 and send them in. And then a challenge for us is self-presenters who come to A&E with perhaps a speech problem that may seem like confusion initially. So those are the areas where we're still finding difficulty to manage.
But if we have a patient, say, whose relative rings us and say, "Oh, my husband has symptoms, we think suggested a stroke," we will tell them to dial 999.
Yeah, fast positive dial 999.
And also advise them to say that we think he may have had a stroke.
Yes,
because that kind of activates.
Use that word.
Yes, exactly. Okay, that's very helpful.
A few slides looking at the outcomes of stroke in London, showing this is death and dependency, showing how we've made big differences in both death and dependency for stroke. And this translates through into reduced cost. So the cost effectiveness of the stroke services in London are essentially because fewer patients are having to stay in hospital for prolonged stay because of disability, and fewer patients are going to nursing homes.
Okay.
So the big picture is that stroke and TIA are treatable medical emergencies, and we've shown that if you organise care in London at a population level, you can make big differences to the population.
Just from the GP perspective, the message I think you're giving is anybody we suspect of having a stroke, we need to either, if it's an acute stroke, they need to go as fast as possible to hospital, that is to say 999. And if it's a TIA, again, as you say, in the first 24 hours, we don't know if it's a TIA, we don't, unless they fully recover from the symptoms, and that we need to speak to the stroke team. And you, I believe, you have or are putting together some
we've
protocols for us.
We've just finished a referral pack.
Good.
Which, I said call the stroke team. Feedback we've had from GPs is that they still would like to be able to use a fax on occasion. So we've got a faxed referral form as well within that, and the referral kit talks about the treatment guidelines that I've been outlining today, the ABC treatment, advice about driving, smoking, things like that.
Right, good. In my experience, I think I've had about 2 or 3 experiences in the last 6 months ringing the stroke team. They've taken some details, and then I've said, "Do you want a letter?" And they say no, and they handle it from then, which is quite, it saves time from my point of view. So, I've found it very helpful.
Faxes are traditional, and people are comfortable with them.
Yes.
But what the data from the Oxfam study show is the fewer barriers you have to access to treatment, the better the results are. So we're actively looking for people with TIAs. So we're welcoming any way you refer them.
Okay.
As soon as we get to hear about them, we'll act on them.
Right. That's I think quite an important, maybe a new message for us, is that actually TIA, as you say, is an emergency, and we have to know what to do in this.
So why I'm promoting phone call is that it means we can discuss the referral with you, and things like getting them mobile and organising to see the patient are easier if the patient's with you. And the moment if you wait to the end of the surgery and write a letter and so on, then you're already introducing delays.
Yes, and also who knows if that fax is going to be picked up at the other end and so on. So
as a system, the target we're measured against is the time between the patient seeking medical help and them starting definitive treatment. So the clock begins when the
They walk
patient
into
goes
see the
when
GP.
they walk in to see the GP.
Yes. Yes. Okay. Well, we will.
So as a health community, we're collectively responsible for delivering that target.
Fine. Oh, this is a good example of integrated care.
Yeah.
Well, thanks very much for taking the time to do this, and I hope it will save you time and improve and reduce the time it takes for a person with a suspected stroke getting into the system.
Thank you.
Thank you.